Good afternoon again. I'll try to move through this quickly, but what I wanted to talk a little bit about has to do with for those of you who haven't used them, the helical endostaple in EVAR. And I have no investments or other conflicts dealing with this product as well. From a background standpoint, type 1 endoleaks and/or proximal endograft migration pose a serious threat to EVAR durability. And proximal endograft fixation is a known deterrent to chronic integrity, determinant of chronic integrity and success of EVAR. So if you have unfavorable anatomy, short, wide, highly angulated, greater than 60 degree, or reverse tapered necks, all these predispose to graft migration in a type 1 endoleak. And there have been lots of methods put out there to solve this problem. Bare metal stents in the suprarenal fixation, suprarenal position extending off the upper end of the endograft are the common ones. Some of these have penetrating wall barbs, some don't. Then you have increased conformability of the endograft, much like the device Dr. The device was just presented, where it's very flexible at the neck. There are several others that have very angulated, tolerate great angulation to their body. You have the endovascular sac sealing system, which I presented to you earlier. You have fenestrated and branched endografts. And then the helical endostaple was designed to be used with a particular graft as an anchoring method for that graft. However, the graft has been removed from the market, but the endostaple has FDA approval as being used in the United States. The staple was developed to enhance endograft fixation as a part of a graft delivery system and an implanting system to repair either type 1 endoleaks or fix the graft. And if you look at the dislocation forces required to displace a graft, once it's been in place, it takes about 20 newtons of force to remove a standard endograft once it's in position. And if you put 4 endostaples, that force increases to 50 newtons. If you put 6 in on the proximal attachment side, it goes up to about 80 newtons. And this is pretty reproducible in a variety of cadaver studies. This is what the Aptus endostaple looks like. It's a delivery system. This is the delivery system right here. It has the ability, much like the Morph catheter, to completely angulate the tip of this to about 90 degrees. This is the control handle, as a flush port. And then the endostaple itself is exactly 3 millimeters in length, and it's contained in one of these preloaded cartridges. You stick the device, you have to reload it every time that you use it. And this is how it works. You actually position this thing right against the aortic wall, you angle the tip of it, and then you deploy the staple, and you can actually see under fluoroscopy this staple screwing itself into the wall. Before you detach it, you can actually remove it and draw it back into the system. So it is not an all or none phenomenon. The limitations of this device are heavy vessel wall calcification, endo-anchor length of only 3 millimeters, maldeployment, which results in an endo-anchor embolus, and the device cannot increase the diameter of endografts with fixed endoskeletons that have fabric attached to them. In other words, you can't make a 28 millimeter graft fit a 30 millimeter neck with the use of endostaples. It doesn't work that way. You have to have fabric that's not attached to the device if you're going to use that as the anchor. So I'll give you a quick case report. A 67-year-old female had bilateral renal artery stents in 2006. She happens to be my next door neighbor. And in EVAR in 2010, she had a type 2 endoleak near the proximal attachment site. We thought it was a type 2 endoleak. There was a pair of lumbar vessels coming into that area. And over a serial follow-up evaluation, she appeared to have about a 3 millimeter increase in sac diameter every 6 months. So in 2013, we took her in and did CT-guided coil access of those lumbar vessels percutaneously from a back translumbar approach. Got into the lumbars, coiled them. We also coiled the sac and put some glue in there, some onyx in there as well. When we were all done with that, everything looked great, except that she still had an endoleak, and what it appeared to be was actually a type 1 endoleak, probably from the fabric being pushed away from the aortic wall by one of the renal stents, which extended into the aortic lumen. So to repair this, we attempted to fix it by using 6 Aptus endo anchors. The complications when we did this were, one, it didn't completely seal the endo leak, and two, we had a endo anchor embolus where the vessel was calcified. The device didn't completely deploy, and it ended up as an embolus and went to a branch of the renal artery. Show you this, what this looks like. You can see here, if you can see, these are the endo staples. This is where we previously coiled and onyx the type 2 leak. This is the endograft. And these are the stents in the renal arteries. It was actually the right renal artery stent which was pushing the fabric away from the wall. Staples here, and if you look here, you can actually see how the staples are actually penetrating into the aortic wall. There's a couple of places you can see it very easily. So when this didn't completely work, we did a definitive repair. We placed a type proximal aortic cuff and then anchored that in place with some Aptus endo anchors. And this is what it looked like when we put the cuff in right up to the level of the renal vessels and put several more endo staples in place. And then this was the completion arteriogram, which lets you see, just to back it up one, I'll back up to here. You can see there's the type 1 endo leak still present right there. And after this second procedure, you can see that it's gone. And the reason there's no flow in this limb of the endograft is because the sheath that's in there is occlusive, but it was widely paid when we finished. So that's all. It's a good option for attachment problems. You have a graft. The graft that does this most is Anurex, the old Anurex device, and we fixed several of these that have migrated by using endo staples to put them in place, and we noticed they're moving south. I'd be happy to answer any questions. Thank you.
Thank you.
Sorry.
Thank you. Do you think that there are some indication to place this system, this device, at first intention?
What's that?
At first intention, you have indication for this device?
Well, I think, you know, the staples were developed to anchor an endograft that was developed to use with those staples. And the endograft itself didn't perform well, and the company's taken that off the market. It never got through an IDE trial. But the staples did, and they're on the market and are very usable. And there are times, for example, we had an Anurex graft that slipped down about 4 or 5 millimeters. There was no leak, no anything, but it had moved down about 5 millimeters over serial follow-up. So we just went in and stapled it into we put 6 staples in. It hasn't gone anywhere since we've done it. And we had a Cook device that moved a little bit, because of angulation, and we stapled that up. And one of my partners did a very angulated neck with a Cook device and was able to staple that in place so that it wouldn't go anywhere. And it wasn't going anywhere to begin with, but this was just suspenders and a belt. Okay. So I think they have a good. The most important thing, the 2 things about this, and I can't emphasize it enough. One, if it hits calcium, it doesn't go through calcium. And unfortunately, that's one of the reasons these things slip, is because the neck has a lot of calcium in it. So that makes it kind of less useful. The second thing is, it will not take a device that's 28 millimeters and take it out, take the cage out to 30 millimeters. Those things won't do that. You have to have fabric available to move out with it, or the device has to be able to expand out to the wall.
Does the aorta get perforated when you're doing stapling? Is the chance of perforation and development of new leak with the staple itself?
Well, that's a good question. I don't know the answer to that. We've used it on all of the devices, and there's no restriction as to what ones you can use it on or can't. I worry a little bit about using it on regular PTFE like the Gore device, because you know that anything that goes through that tends to make a hole that may enlarge around that hole if there's any tension on it. Even sutures do. So I worry about that a little bit, but it certainly works fine on Dacron. And the interesting thing is, we had one mal-deployed. So it drops into the aorta. The patient's laying down on their back. It's laying in the aorta. It doesn't, you would think it would be gone, okay? It lay there for 30 minutes. I tried to get it out with a snare. I tried anything you could think of to pick that endostaple up and get it out. And then all of a sudden, it was gone out the renal artery. Went out to a branch, a tertiary branch of the left kidney, and it's not occlusive in that branch, and it's still open. I just saw a CT scan on the lady as a follow-up, and she's got flow by it, and it's not going to hurt anything even if it blocked it off. But the thing that I was most amazed at was it just laid there in the aorta and didn't go anywhere. It was right against the aortic wall. It wasn't stuck on anything. it was totally mobile. I could push it around with the snare, but I couldn't catch it with the snare, get it back out.
Thank you, Professor Buckley.
Okay, well,
It was nice.
Sorry, can I just ask you a question? What do you think, how much of local stress it will cause having used a stent graft, then aortic cuff, and then this endo?
Well, I think it's probably a lot of stress on it, but, you know, either that or explant. And this lady is old, she's had coronary bypass surgery, and she's got a little bit of renal insufficiency. There's lots of reasons for not.
Probably if you use appropriate sized one, the stress would be less. If you stretch the graft too much.
Okay, we have to move on. And Dr. Atul Mathur is there, I think so.